Hello, good evening. This is Dr. Stephen King. I'm faculty at UAMS Family Medicine. I am going to give you a little tutorial on suturing and stitches. And just to let you know, the ideas that I'm giving you are mine and mine alone, as well as all of the equipment I'm using and not the input of my employer or anyone else. So what I'm going to tell you are some tips that I've learned over the years from different people. And what I found is that some things work for one person and not for another. And you might find that part of something may work for you, but the other part doesn't. So I'm just going to give you some ideas. I'm going to try to limit things to what we'll be doing in our suture workshop soon, and not go too far. There's a lot of information that we could prevent and will present, and perhaps in a later video we'll talk more about some of these other things. But first of all, I just thought I'd mention holding the needle driver and how to basically do that. So normally you'll be taught to hold it like this. I would advocate, especially if you're going to be doing a lot of suturing, to palm your needle driver, to hold it like this. And sometimes this will be helpful to put your index finger here. I often don't, and it somewhat depends on the size of your needle driver. And at first it takes a little while to learn how to do that. And the best way to learn how to do it is to get one of these that's in a disposable package. And that's a good one to do because the action is not that good on those disposable packages. And get that and put it in your pocket or your lab coat and leave it there for 2 to 3 months. And whenever you have a chance, reach in your pocket and just go back and forth. Just click it and click it back and just play with it. And it does make noise, so you don't want to irritate your colleagues. But anytime you can do it at home, and it will take some months to get comfortable with it. But I think over time you'll be glad that you did it. So give it a try, and if it works for you, I think that would be good. The other thing is I wanted to show you is just the basics of loading the needle into the needle driver. And I'll get my suture, which is a nylon suture. This is looks like it's a 4-0. Feels to be kind of a thin 4-0 to me. So what you'll be taught is to load your needle driver at the border of 2/3 and 1/3. So you back in about 2/3. I find that often I'm probably just beyond that. Another thing that I'll do is instead of just making it perpendicular, I will angle it up a little bit. And in certain types of stitches, you may find that you'll angle it up even more. So that's basically how you get it. And I'll just throw one stitch in there to give you an idea. The other thing to keep in mind is to go perpendicular to the skin and then bring it out, and then come out the other side directly opposite, grabbing the same amount of skin and going the same depth. And what I like to do is I like to drive it forward and get it ready and set up to how I'll be doing next. I'll be using it next. And so that's basically it. And we'll go over more of this shortly. Now, the other thing to keep in mind, you'll be using a forceps. Most people are going to be recommending forceps with teeth because it usually is a little less traumatic on the tissue. However, it depends on how you use your instruments. Most of my surgery teaching came from a pediatric surgeon, so we actually used without a forceps without teeth, and it was slightly serrated in there at something like maybe this side, and it was just the way we grasped tissue. Now you can also get an instrument, and in a later video I'll see if I can find my old sets, and the serrations are larger and they're sharper, and if you really need a good grip, that's good to have. You probably don't want to be doing that on the skin. So, but the majority of folks find for adults they may like this better. Okay. I'll also talk briefly about numbing medicine, lidocaine. That's what that's what we mostly use. And a couple of things that I've noticed is that when you go to inject into the skin, you try to get more parallel to the skin, slightly angled. Obviously you can't get perfectly parallel, but get a little more parallel rather than this and more perpendicular and trying to go in. You want to get more parallel, and the main thing is you want to get through that skin quickly, and I usually do that by stretching the skin out and then popping through quickly, because it's going to hurt more if you just take your time and camp out for 10 minutes, slowly going in there. That hurts. But you pop through, and then you slowly inject your lidocaine. I use in adults 1% lidocaine is probably good. In kids, you may want to use 2% lidocaine, because you have to go up to 2% lidocaine to get rid of the touch receptors. In kids, when they're 3 and 4 and 5, it doesn't matter if it's sharp or dull. If you touch them, they don't like it. Another thing about the lidocaine and marcaine, for that matter, is it does burn. So a couple of things you can do is mix a 10% bicarb solution. That will help. You can warm it in your hand and get it room temperature. You can do it if you have time or your nurse, or if you have a heating pad, put it on low, put it there for about 5 minutes, and you'll be good to go. And the other thing to remember is to take your time with the injection. Go painfully slow. Take your time. That helps with the burning. So I think those things might help you. The other thing is, we've always heard the little mnemonic, fingers, toes, penis, nose, never use the epinephrine. Mostly that's gone anymore. You can pretty much use lidocaine with epi as long as it's commercially made everywhere. There actually was even a study with digital blocks showing that this was actually just fine here as well. A lot of times on the nose, you might especially want some epinephrine because it gets so vascular and bloody. There might be, I still think I'm probably not going to be given lidocaine with epi for digital blocks and deep in my vasectomies, but it's just to make the point that lidocaine's pretty much, you can use it pretty much everywhere. Okay, and then one other thing, this is what I do. When I numb something and I need a little time, for example, if I'm numbing, taking a toenail off or injecting a knee, which is not really in the scope of what we're going to talk about today, but laceration even, that's going to be hurting, you think, for a while, especially if it was deep. You might want to mix lidocaine and marcaine. Now, marcaine will give you more numbing time, and the epinephrine also extends your lidocaine out as well. And you can mix them 50-50, and you can either do a 1% lidocaine and 0.25 marcaine. That's what you'll most commonly see. But if you want to get if you want to end up with a 1% and 0.25%, start with 2% lidocaine and 0.5 marcaine. You can get both of those, and then you mix those 50-50, they dilute out, and you get 1% and 0.25. Okay, so I'll get set up here real quickly, Beth, and you can, well, welcome back. I just wanted to continue on a couple more things, and a little more on numbing your wound. And don't forget, if you've got a laceration, especially in kids, don't forget about let. It is, it's very helpful in kids. You have to let it sit for a while, but it will be very helpful in kids. Also, you can consider injecting from inside of the wounds. That won't hurt, and you can inject into the skin from there. One caveat, if it's a dirty wound, you want to make sure and get that cleaned out, because theoretically, if you got a tiny particle, you can drive it into the tissue more deeply, or if you can't, if you need to numb it first, you may just want to numb it on the outside. As far as cleaning, it's now well known, and it's a board question, that tap water is as good as saline. And so I recommend you use that. Don't use hydrogen peroxide or chlorhexidine or betadine. You may want to give some irrigation, and you can irrigate it. There may be a device in your ER or urgent care or possibly in your office that you can irrigate with that, and that'll work well. They say 5 to 8 pounds of pressure per square inch, but of course that means nothing to me. You just need to use what's effective. One thing that I have seen used and I adopted myself was getting a little, what would you call this, a spritzer, and you can use that, and you can adjust your spray to a stream, to something more broad. You can get close, you can pull back, and you can get a large volume in there and just irrigate and do that. And you know what also is very good is, wash things with soap and water. Have the patient wash and rinse in tap water with soap and water. As far as gloves, we always think, oh, we need sterile gloves. Well, we probably don't. We probably just can use non-sterile gloves. I would suggest around the patient, don't say non-sterile. I would just say clean. You ask the nurse for clean gloves if you need to make that distinction with her. So, types of suture, what you'll be using will mostly be, for skin, you'll be using some sort of nylon for the face. You probably 6-0 for the neck, the rest of the body, probably 5-0 if you're down, in the leg or arm, you might need 4-0. And then you may also need to use a deeper stitch, an absorbable stitch. And the one that you'll be using primarily on the skin will be Dexon. It'll be mostly 5-0 Dexon. You might occasionally need 4-0 Dexon to bring together some deeper tissues. If and that takes about, it'll be around 3 weeks. It loses its tensile strength gradually, but it'll be there probably that long. It actually be reabsorbed may even take longer, but it loses its tensile strength over half of it, probably by 3 weeks, or most of it. Now, if you happen to be working on hands and doing an extensor tendon, and it's okay to repair an extensor tendon yourself if you see it, you get good visualization. I would probably repair it with Vicryl, which is absorbed on a little more prolonged, and it'll probably be present at least a couple months, and that you want something for a while to hold the tendon together. And it depends on the situation, but you may want to do a horizontal mattress, and maybe an additional stitch, depending on how it looks. Those, when you get those, you may want to cover that with an antibiotic, and then put them in a splint and send them to an occupational hand therapist. Now, if you have a flexor tendon, you want to send that to your hand person. Just get that cleaned up and approximate things and send them on as soon as possible. So those are kind of some of the big things you'll use, other than Dermabond, of course. And you can use Dermabond with steri strips. I would recommend caution when you use Dermabond and stitches. Because the stitches can be real hard to get out if you got glue on them. That's the only thing about that. You might, if you had a real long wound, and you might want a stitch or two in the middle, and then glue on the two ends. So that might be the case there. Another thing about Dermabond is you don't want to put Dermabond on in a bite, is that'll trap the bacteria in there, and you don't want that. As far as antibiotics, while we're on that subject, the antibiotics, maybe you need to consider, like if you have an open fracture, you may want to give prophylaxis for MRSA. And if you have a dog or a cat bite, a dog bite, if it looks pretty clean, you get it cleaned up pretty good, and you want to repair that in a loose manner with just some reasonable approximation, that's okay. A cat bite, I would not repair that, and that definitely needs an antibiotic. The dog bite, probably, especially if you're introducing some stitches there. But the cat bites it's more of a puncture type of injury, and drives the bacteria more deeply, and augment is usually satisfactory there. Okay. So first, I just want to demonstrate some stitches interrupted, then we'll do a running, and then a locking, and then show you how to close with an Aberdeen knot at the end, which is it's something worth knowing how to do, and there's some that say it's actually better. So again, loading the stitch, and you can see that I've loaded this angled up quite a bit, and you see my bias is probably beyond 2/3, and then angled up, and that's just the way I've done things. That you'll find out what works good for you. So first we'll look. Okay, so this is a little wound, a little laceration we have here, and so remember, perpendicular, and dive down, and then you'll grasp it, and if you can go all the way through, that's great. If not, you'll grasp it, and then you're ready to go on this side, and then right straight across, and about the same amount of tissue you want to grab, and then you pull it tight. Most of what we're going to be doing is instrument ties, but I'll talk a little bit about other ways to tie a knot. Now, because if you're tying a knot another way, you got to keep in mind that, this needle can be a weapon. Now, if it's attached to this, it can be a weapon. You leave it there, you forget about it, and you poke yourself or somebody else does. If there's not much between your towel and the patient, you'll poke the patient. There may be a time when you want to have it up. And if you're ever, you just want to be compulsive and sure, you can just clamp your needle and clamp it like that. But for an instrument tie, you can just leave it loose, that's fine. And then usually you're basically doing a square knot. Your first tie is going to have 2 loops. And usually about 4 or 5 loops is what you want. There is a technique I've seen where someone on the 3rd one goes and does another 2. So that's an option if you want to do that, and then cut and you're done. Or you can just keep on and do your 4 or 5. So I'll just put in 5 here. And then on that 5th one, you might want to get your stitches onto the same side. It just makes them easier to negotiate when, as you're putting in your stitches and tying your knots and ultimately taking them out. So you want to kind of get them out of the way. Okay, so now there I've got it more 2/3, 1/3, and that's going to work just fine. So this one I'm going to again throw 1 stitch in. And let's say that this wound is somewhat irregular and I'm not sure where I need to go on the other side. So if your stitches get slightly wet, and often they do with a little bit of blood, pull it over where you think you'll want it to go, push it down, and that'll put a little line of blood where you're going to want to go. So that might be helpful, especially useful in sub-Q stitches. Okay, so I'm going to run these. So I've grabbed it and I'm ready to go from my next stitch. And then you can, so if I'm holding my needle, of course I won't be able to do an instrument tie, but I can just go ahead and tie, I'll just put in a number of stitches. And then just the first throw, I can only put 1 in. Now, what you can do, it doesn't completely pull it over. So I want to tighten it up. And so there it closed pretty good. And in general, your first throw and tie is going to be looser, and you progressively get tighter as you bring the knots down on the knot. And I recommend practicing left-handed and right-handed single-handed ties because, as you can see, I'm tying with my left side, and it's taking me a little bit longer. Okay, and so we'll just cut this 1 stitch here. and then we'll make a running. And you can do this on lacerations. Some people actually prefer it because it is faster. And nylon can be a little bit harder to negotiate because that stitch kind of gets. And now I'd like to show you a subcuticular interrupted stitch. I would say the most common stitch you will use is going to be 5/0 Dexon, maybe 4/0, but I found that most of the time I'm using 5/0 Dexon. And the purpose of this is when you want to take some tension off of the skin suture, so you want to bring that deep tissue a little bit better, a little bit better proximity, closer proximity. So if you look here at my wound, so I am going to grasp subcutaneous tissue. Now, it's important to remember to start with the underside.
Churches.
Okay, I'm just going to introduce a few more stitches and then that'll be all for this episode. So I'm going to, this couple of different things, a horizontal mattress and a vertical mattress. Horizontal mattress, basically you're getting a larger chunk of tissue and bringing things together with a larger bunch of tissue. Okay, so you make your mattress, you go on one side, stay on the one side of the wound and come out the other. You want to get a pretty good bite, probably bigger than that I did. And grasp your needle about like you're going to want to do it. And okay, so I'm going to redo that stitch, everybody, on the horizontal mattress. So a couple of things. Go in like and this is to bring together an amount of tissue to take tension off the wound. So take your bite. You might envision in the usual manner. You take pretty good sized bites. Okay, and on what you do next is you're going to have to backhand. So get your suture backhanded. And then on this side, starting on the same side that you were just going on, come through to the other side about, might want to get a little more real estate there. And then there you have it. So start on one side, go to the other without interrupting the stitch. Bring that together, and then you can see you can bring it together actually pretty nicely. And then you can tie it in whatever manner that you would like to. I'll just pull that out before tying it up, and then I'll demonstrate just quickly the vertical mattress. And again, you can start on one side, pretty good piece of tissue. Let's start over there. Okay, starting with a vertical mattress, come through as you would always. And then again, you want to backhand. And then this time, take a lesser bite. And you may need to do this in 2 steps. And then that'll give you a pretty good piece of tissue. And you bring that together. One other thing I will mention, and this is a half-buried mattress. Say, for example, you have a laceration that's a Y-shaped. You have a V-shaped laceration, actually a piece of tissue up here. And envision this piece of tissue, I'm not sure I can separate it on this model, that it's a flap. So the half-buried mattress, you start going through the skin on one side. And envision that this is a flap. You'll reach up underneath it along in this area and get some subcutaneous tissue. And you'll just grab that. My needle is starting to show little signs of wear here. It's getting a little bit bent. So we don't want to cross those like I did there. And then your last throw will be on the other side opposite this stitch. Okay, and then you'll pull that down and you'll hopefully get some pretty decent approximation. So again, you want a couple of throws. And if you grabbed a pretty good piece of tissue, it'll bring that V down. If you have an assistant, they can keep that tension there, or you can bring progressively increasing stitches if they withstand the pull. There are some tricks you can use to keep your stitch from breaking like that. Okay, well that'll get you started. There are some other techniques and knots, and we'll show those in a later video or an edited video. And I'm going to be having Dr. Kim and Dr. Denblurry help me edit this so it can be a little smoother. Or if you have any ideas, please send me an email or a text. Thank you very much.